Good evening and warm welcome to the MedTweetMY professional webinar session. We express our sincere gratitude to each and every one of you for joining us today. The overwhelming response from participants is truly inspiring. What began as a modest Zoom meeting now has blossomed into a platform capable of accommodating a substantial audience. Moreover, we are proud to announce our successful collaboration with various industries to facilitate continuous medical education. At MedTweetMY Professional, we are committed to providing exceptional learning experience, ensuring that our esteemed speakers are recognized experts in their respective fields. And the best part, all of this valuable knowledge comes to you completely free of charge. Today, we have the privilege of hosting a speaker who is not only a member of MedTweetMY community, but also someone I have had a pleasure of journeying alongside for the past 2 years. Despite working at a different institution, HKL and IGN, we have never had the opportunity to meet face-to-face, despite our occasional collaborations. Allow me to introduce Datuk Dr. Alzamani, a consultant in emergency medicine at Hospital Kuala Lumpur. With extensive experience in emergency medicine and a strong commitment to humanitarian efforts, he is a highly respected figure within the field. Dr. Alzamani will be sharing invaluable insight on the topic of approach to headache. Before we begin, I would like to remind you that the link to claim CPD point will be posted in the chat box at the end of the session. Please note that the link will only be active for a duration of 15 minutes. Additionally, if you have any questions, please feel free to submit them in the Q&A section. Without further ado, I would like to invite Datuk Dr. Alzamani to take the floor and enlighten us with his expertise. Datuk?
Thank you, Dr. Iskandar Mirza, for the kind introduction. I think I will share the screen with you now and check if you could view my slides.
Yeah, clear, Datuk.
All right. Okay, so all right, I think I was told that there are more than 600 people viewing this at this moment. So I presume there are lots of people with headache problem, yeah? And I suppose before I start, maybe I will tell you a story. This is a story of a woodcutter that long time ago, there was this woodcutter who would usually, go into the forest, cut trees, and then sell the wood, and then give money to the wife. And then one day, as he passed by a river, suddenly the axe dropped into the river, and then he cried by the river because he has lost the means to get income. And suddenly there was a genie that came out from the river, and the genie asked, "What's wrong with you?" And he said, "I've lost my axe." So the genie felt sorry and then went into the river, and then wanting to help that man, brought out a golden axe and asked whether this is your axe. So this woodcutter said, "No, that's not my axe." And then the genie again went into the river for the second time and brought out a silver axe and asked the same question. And again, the woodcutter said that, "No, that's not my axe." And finally, he went into the river and brought out his rusty old axe and asked, and this woodcutter said, "Yes, that's my axe." So feeling very impressed, he gave all the 3 axes to the woodcutter, and the woodcutter became rich because he didn't even have to work anymore. So that was lovely. But one day, he was walking by the river with his wife, and suddenly the wife fell into the river. And this time, the woodcutter cried again by the river, and again the genie came out and asked, "What's the problem now? I thought you're already rich and happy." And he said, "Yeah, but right now my wife fell into the river." And then he said, "Okay, since I know you, I will help you again." So this genie went into the river and then brought out Taylor Swift and asked whether this is your wife. And the woodcutter said, "Yes, that's my wife." So the genie was very disappointed and said that you have changed. I thought you were honest. And he said, no, it's not that I've changed. If I were to wait for you to bring out Taylor Swift and then Kim Kardashian and finally my wife and ask me to bring all three back home, with one wife I have headache. Now with three wives I would have 3 times the headache. So I think that's all my presentation tonight. No, it's actually I just want to give some time for more people to come in. So we're talking about headache tonight. Again, thank you to MedTweetMY for inviting me to share this presentation. My goal in this presentation is for us to recognize different types of headache, and especially in your clinical practice, you will be able to differentiate the types of headache and also provide the treatment that's relevant. Okay, so let's move on. Yeah. So now you might be wondering which countries in the world are having headaches. Maybe it's Malaysia, but this is actually the prevalence of migraine in the data. The redder it is, the more headaches you have. For example, in Spain, in Italy, in Austria, and even in Nepal. So we were somewhere blue. So we were somewhere in the middle. It's probably interesting to find the reason why there are so many people in Spain, Italy, and Austria having headache, and also Nepal. Anyway, I have a theory for Nepal. I'm not sure about Spain, Italy, and Austria, but I'll tell you about it later. This is again in terms of tension headache. There are more in Afghanistan, in Brazil, in Paraguay, and we are again somewhere in the middle. So this is the outline of my presentation, and we will look at some of the global data, the types of headaches, some of the latest NICE guidelines, some of the diagnosis updates, some of the treatment updates. We shall take a look at subarachnoid hemorrhage, because this can be a deadly thing, and we need to be able to detect it. And the use of opioids in treating headache, and some of the recent developments. So right now, the global data has shown that there are like 3 billion people having migraine or tension type of headache, with half of the diagnosis. So you could see that this is the top causes of headache. You either have tension type headache. Actually, it's more of tension type headache, double of 2/3, and 1/3 of that is actually migraine. And migraine has worse disability than tension type headache. Tension, you selalu kerja or with boss, or you get tensed about that, yeah. But migraine is more innate, and it is most burdensome. The headaches most burdensome in women between the ages of 15 and 49 years. This is according to a Lancet Neurology Journal published in 2018. So let's take a look of these types of headache and think about what could be the cause. You may guess the diagnosis. Case 1, a 27 years old lady having one-sided throbbing headache, presenting with nausea and vomiting, and preceded by flash of light. Case 2, a 36 years old man having a tight band headache with a lot of work at the office and having strained relationship with the boss. Case 3, a 41 years old gentleman having pain around the left eye and left forehead. It covers the eye and one-sided of the eye and the forehead, plus it also involves the eye, which was reddish, and also have some nasal congestion. That's very unique, yeah. Case 4, a 72 years gentleman, a bit elderly, fell while jogging and lost consciousness for about 3 minutes, but regained full GCS after that and being able to walk again with no symptoms. He had been having actually headache and intermittent amnesia, but full functioning, full GCS. Case 5, a 45 years old lady with hypertension. She was watching the television and suddenly had a sudden, most severe headache. And case 6, a 36 years old man who was COVID positive, and he said he can't smell. And after the COVID, even during the COVID, and even after that, had been having severe, persistent throbbing, one-sided headache. Sounds like migraine, but He only got this after getting COVID, and that lasted for a week. So the diagnoses are this. Number one is a classic migraine, that it is one-sided, it's throbbing, and it's preceded by aura, like flashing of lights or some smell, and you know it's coming. Case two is classic tension headache, usually because of tension situation. Case three, this is very unique, it's called cluster headache. So it's one-sided, and involves the eyes, the nose, the adjacent areas, and the forehead, one-sided. And case four, now this is a case, actually a real case. So this is a case of acute on chronic subdural hemorrhage that you tend to see in elderly patients. So when they come, sometimes they have like altered memory or altered mental state. And when you do CT scan, you do see this acute on chronic subdural hemorrhage. Case five, the most severe headache ever, all of a sudden. So they were always worried about subarachnoid hemorrhage. Some, they have the most severe headache, and then it just subsides a bit, but it's still there, but full neurological function. But some straight away they got into syncope, meaning that this the bleeding is massive, and usually these people, they have aneurysm. Subarachnoid hemorrhage could also occur in trauma, non-aneurysmic cause. So they also present with that. And finally, this is in lieu of the recent pandemic. You could have what is termed as COVID headache. It has been acknowledged to be a type of headache on its own due to this COVID. So this is international classification of headache. And there is a headache society. So you might want to, there's an international headache society. You might want to apply to be a member, but I just wonder whether the council members have headache running this society. So many people with headaches. Anyway, this is the classification. You basically have a primary headache, and you may have a secondary headache. So primary headache, usually there's no causative, there's no cause to it. It's like very innate. And these two tops everything, the migraine and the tension type headache. In fact, the tension type headache is more frequent compared to migraine. There's also other causes, other innate cause is also deemed as primary headache, like trigeminal autonomic cephalgia and other primary headaches. But for part two, this is a secondary headaches caused by trauma, for example, vascular disease, excuse me, other intracranial pathology, substances, CNS infection, meningoencephalitis, TBs, even dengue sometimes, homeostatic disorders, cranium, neck, eyes, ENT, sinuses, mouth, teeth, TMJ disorders, or even psychiatric disorder can also lead to secondary headaches. There's also part three called on its own, standing on its own, called cranial neuralgias and other facial pain, very much related to neuralgia. And this is due to neuralgias and neuropathies. So this is the headache NICE guideline, been updated on 12 May 2021. This is some of the information that have been updated. For example, in that guideline, one of the treatment of headache and analgesia in the form of gabapentin had been removed from recommendation. In 2015, there was also a new recommendation on the prophylactic treatment of migraine, particularly involving the use of propranolol, because there was a worry of propranolol overdose in people having migraine who also have depression, because they may abuse that. Because it's very difficult to treat beta blocker toxicity. And in May 2021, in terms of topiramate as a drug, as for prophylaxis of migraine, there's some discussion of the potential benefits and risks and the importance of effective contraception for women and girls, because topiramate can be teratogenic. So one has to be careful, because sometimes you don't realize you're pregnant, but if you take topiramate, it could cause teratogenic effect for the fetus. So now we go for the primary headaches, and when we want to differentiate the types, So when we look at the this tension or migraine or cluster headache. Yeah? So I've actually, from the first the slides of the cases, I've given you the classic presentation of someone having the first one just now was a migraine, whereby it can be usually unilateral, but it can also be bilateral. It's throbbing and pulsating. It can be between moderate to severe, and you could sense something is coming. You may have nausea, vomiting, very sensitive to light and even to sound, can present with or without aura. Visually, you can be in terms of flickering of lights, seeing some spots, some lines, or even vision loss. It can be in terms of sensory, whereby one would feel numbness or pins and needles, or even speech disturbance. Compared to tension headache, it's usually bilateral. It's like a tight band around the head, very tight. And it is usually not aggravated by routine activities. And it's usually lasts about 30 minutes, and it can be continuous. But for migraine, it's typically lasts between 4 to 3 days, between 4 hours to 3 days. So, but there's an absence of the aura for tension headache. For cluster headache, it's usually one-sided when you see that the eyes are red and the periorbital areas involved, the foreheads involved, and then maybe also nasal congestion. So this can last even much longer, up to 5 days. So it's usually a one-sided, and a bit like your RTI-like presentation at the same time. So that's a cluster headache. These are primary headaches, which are most common, but again, tension headache is more common compared to than migraine, than cluster, but these are like top on the list. You can have a headache due to sinus as well. Well, this is the cluster headache around the eye, the tension like type by the migraine one-sided typically that can be presented with aura. So apart from that, the guideline mentioned about this, that the headache, each of these primary headaches can be deemed as episodic or chronic with some criteria. Usually, the episodic form of headache lasts less than 15 days in a month, half of the month. Well, for the cluster, it goes between 1 every other day to 8 times a day, plus at least more than 1 month pain-free, as compared to chronic headaches, whereby typically they last 15 days and above, and some can even go even months. But for cluster headaches, it's there up to 8 times a day, this and with a less than 1 month pain-free in a year. So how to know which the best is to do a headache diary, and which is recorded for a minimum of 2 months, and for which with the characteristic of the headache, that what could differentiate between the episodic or chronic headaches. So sometimes it's also seen whether there's some relationship of headaches to menstruation. Interesting, with menstruation. Yeah? So I will touch on the menstruation in a while, but before that, there is also this thing called medication overuse headache, meaning that the headache is due to medication overuse. You think about it, someone having headache may be taking painkillers, but when they take too long, those painkillers become the cause of the headache, and this is called medication overuse headache. And the criteria for that is that a headache that develops or worsen for a period of 3 months or more upon taking this either one or a combination of these triptans, opioids, or ergots, or combined for 10 days or more in a month. So meaning that someone who takes painkiller for a third of the month or more would be a subject of having this risk of getting medication overuse headache. But if they're using, the less stronger analgesia in the form of paracetamol or NSAID, they would it will be for someone who've been taking this for a minimum of half of the month, meaning that 15 days or more. So someone taking this much of painkiller can end up having this persistent headache called medication overuse headache. So the treatment is that you just have to stop taking this analgesia for that much. So meaning that the treatment had not been optimized. So yeah, so this I had to be watched out. Yeah. So now let's take a look at the tension type headache, the #1 cause of headache in the world. So for acute treatment, the recommendation is to use NSAIDs. Paracetamol first. Well, if it doesn't work, the second line would be the NSAID, and aspirin is one of them. But one has to be, avoid aspirin for someone less than 16 years because there have been reported race syndrome caused by the aspirin. And the recent guidelines is not favoring opioids. So someone who comes with severe headache, you should go for NSAID compared to opioid, because the opioid can actually cause someone to have more frequent episode of headaches. It may work initially very good when you give it because it's very strong, but for someone who has this habitual headaches, giving opioids can make them have more frequent headaches later on. In terms of prophylactic treatment, the guideline has even acknowledged the use of acupuncture. So this is one of those that could be considered for chronic type tension type headache prophylaxis, where we talk about just now what falls under the episode of chronic type tension type headache prophylaxis. So for those who had this chronic situation, one of the acknowledged treatment is acupuncture as well. For cluster headache, you basically need oxygen. So you need to give the patient 100% oxygen at the minimum of 12 liters per minute, basically a high flow mask for patient, non-rebreathing mask plus reservoir bag. So oxygen is #1, that's the treatment. And can consider if that doesn't work to add subcutaneous or nasal triptans. And it is not recommended to offer paracetamol, NSAID, opioids, ergots, or oral triptans as the first line of treatment. So that's cluster headache. So for cluster headache prophylaxis, this calcium channel blocker, verapamil, apparently can help to prevent if one keep on having this episodic or chronic cluster headache. Now let's look at migraine. So migraine, whether it comes with or without aura, doesn't make a difference. But for acute treatment, the recommendation according to the guideline is a combined triptan plus NSAID. This is like the if you have no financial limitations, the oral triptan will be the #1 choice plus NSAID, or you could combine triptans with paracetamol, or as a monotherapy, just oral triptan or NSAID, aspirin as also part of NSAID, high dose aspirin, or paracetamol. In our setting, it's very difficult to get a triptan because of cost, but I'm not sure in private setting. But I think the best, more sensible way to approach this is to start with the lowest NSAID first, like paracetamol, and then going up the ladder of NSAID, and triptan can be considered later. So between age 12 to 17 years, there's also nasal like this, sumatriptan nasal spray. Nasal triptan can be considered compared to oral triptan. Mentioned earlier on, aspirin is not for those under 16 years old for the fear of Ray's syndrome. So for oral, or if oral or nasal triptan is not effective, then one can give an IV the non-oral ones in the form of the injection, including plus metoclopramide or chlorperazine. For treatment of migraine, even though one doesn't have nausea or vomiting, it is recommended that it does help if you still give anti-emetic like metoclopramide anyway, even in the absence of nausea and vomiting. No ergots or opioids for acute treatment of migraine. So they really go away from using during the acute treatment of using ergotamine, ergots, or even opioids. So this is some of the prophylactic treatment for migraine. I mentioned just now that topiramate had been used, but we fear for fetal malformation. Propranolol had been used, but there have been reported cases of those who had an overdose of propranolol, especially for those having depression. So that's why these are, they're quite careful giving propranolol for as a prophylaxis. But we just know that, if you're a guy, you have pretty bad migraine, you're not worried about being pregnant. Yeah, so this topiramate is not an issue. Propranolol for someone that you trust, they're not depressed or having suicidal inclinations. So this is some for migraine with aura. You may need to investigate further for someone who may be having motor weakness or double vision or visual symptoms, having poor balance or decreased level of consciousness. This can be mere aura, but if this present, we worry that this is the development of something which is not migraine, i.e. stroke. So you need to be careful for someone who thinks that this is aura, because it can be another pathology, and that you will have to go for investigation, like having a CT scan, to be sure of this. Now, why triptan is given importance or given being put high on the list? Because sumatriptan, for example, often relieves other symptoms that occur together with migraine. That's quite unique. If you see a tension headache, they don't go for these triptans because they hardly present with other symptoms like auras, nausea, vomiting. But migraine is quite unique that they present with all this, and giving the triptans help to address all these issues one go. So this is the example of triptans. So it's basically selective 5-hydroxytryptamine receptor agonists. That's the scientific name of these triptans. In short, we just call them triptans. And it has all this function, like reduce neurogenic inflammation, lessen the vasoconstriction of meningeal vessels, modulate second-order neurons, causing vasoconstriction, blocks release of vasoactive peptides and neurotransmitters. So the cause of migraine is still mysterious, but apparently these triptans address all these issues, which are believed to be partly responsible why someone having migraine is having a headache. So there are many types of triptans, but one should start with something which is cheaper. So typically we have sumatriptan, but there are other types of triptan. So the cost is an issue because it's quite expensive. And usually we don't readily prescribe this in the emergency department setting. It's usually in the neuro clinic that they have this option. So this is some of the things that we talk about the prophylaxis just now, in the form of just now mentioned about topiramate and propranolol. One more is this amitriptyline, and as a prophylaxis is also acupuncture has come into the picture, and riboflavin, but gabapentin has been taken out of this as a prophylaxis. Interesting, this amitriptyline actually is quite good. It's actually an antipsychotic drug, but it's quite effective for those who with the ordinary treatment still not effective. So there are options so as to avoid the overuse of the the painkillers that could result in the medications overuse headache by using the all these options to prevent the headache even. Yeah, so interestingly, one time when I was doing an attachment with a in the neurology department, that one lady kept having chronic headache, every time, for the longest time. And this neurologist was, I think, quite brilliant. And he just asked, do you have, does this headache coincide with your menses? And she said, yes. So apparently, he thought that this patient may be having an endometriosis that has gone, that the cells have gone to the brain, that every time she gets menses, she will get headache. So I thought that was, wow, out of the world diagnosis. But the patient was given this amitriptyline, and he was quite well after that. So I think that diagnosis is not that the initial impression that could be made, because if a houseman says that, oh, I think this patient has got endometriosis in the brain, people will laugh. But when a neurologist says so, people will say with respect and awe. But I think it takes a lot of steps before you reach to come to such a diagnosis. Yeah? So we mentioned about the menses, this menstrual related migraine. So there is this thing called menstrual related migraine. Well, on one hand, that neurologist was saying about endometriosis, but there is this thing called menstrual related migraine. And to diagnose that, one has to have migraine 2 days before and 3 days after menstruation in at least 2 out of 3 consecutive menstrual cycles. So this is the criteria. So again, to know for sure, you should make a headache diary for at least 2 menstrual cycles. So you can give standard treatment, the usual paracetamol, NSAID. But if it is not effective, this is some of the triptans is recognized or acknowledged to be tried on these patients. So there's also migraine during pregnancy. Again, the #1 treatment is paracetamol, and triptans or NSAID, after discussing the woman's need for treatment and the risk associated with the use of each medication during pregnancy. So triptan is quite relatively safe, can use during a migraine also. For NSAID, if it is used 20 weeks or more, we worry a bit like the medication overuse headache, or it can also cause serious kidney problem in unborn baby. So I think this would have to discuss with the neurologist that you can actually consider take triptan. So now we have this headache like tension type, migraine, cluster, or even medication overuse headache. Now the question is, should we neuro-image everyone? The answer is no, not for reassurance. So this is very much clinical. If the presentation is very classic and there are no motor or neurological weakness, we hardly need to neuro-image everyone. Now, this is the thing that we mentioned just now about the concerns for opioids use for headache. So why people are apprehensive these days to use opioids as the first line to manage headaches, because the routine use of opioids would lead to more frequent and severe headaches. It may relieve you now, but the future headaches may be bad. And recurrent pain occurs with estimates ranging from 23% to 71% if opioids use. And there's a high risk of medication overuse headache, like we mentioned, when used more than 10 times per month. Also, I mean, opioid themselves can cause this medications overuse headache. And one that we don't want, so one can easily become dependent. Okay, now we move on to secondary headaches. So secondary headache is caused by something else, some other pathology. It's not innate. So we need to look for some red flags for secondary headaches, which should actually push us to investigate and to be careful about that patient. This is one of the acronym of SNOOP, looking for other systemic symptoms cancer, immunocompromised infection, mild, because sometimes, cancer can get meds, TB, you could get TB, meningitis, the immunocompromised, the retroviral infection, you can get opportunistic infection, toxoplasmosis and such in the brain. So watch out for someone who has headache, but having those, we have to start thinking about that possibilities of being caused by secondary pathology. So someone who has neurologic problem, always you have to investigate further the onset of this headache with maximal intensity. It's not gradual, and it just palm, like what we call thunderclap. So this one needs to be immediately investigated, because we fear for the worst headache ever, or the subarachnoid hemorrhage, which I described early on. Someone having, before this was well, usually someone having migraine, they already have it before the age of 50, but after 50 years old, and suddenly you have headache. Now, this is something that warrants for investigation as well. The progression, that it progresses, the pattern becomes severe, and it's just worse and worse. That something is not right. If it is precipitated by Valsalva, this is also actually triggers us the possibility of intracranial pressure cause of headache. There is something inside the brain that warrants investigation, or even from postural aggravation, meaning that there is something which is causing something else which is causing the headache. Someone coming with papilledema, for example, also has to be investigated, or exertional provocation. So meaning you do something, the headache worsens. Now that means that it can be caused by something else other than headache. This is the subarachnoid hemorrhage that we mentioned just now, about this aneurysm that bursts, and this is characteristic of thunderclap headache, that within minutes you get severe headache. So this is some of the decision rule for emergent neuro imaging, whether to CT or not to CT. There is this thing called Ottawa subarachnoid hemorrhage rule. So this is if patient has one of these, then you need to CT the patient. Symptoms of neck pain or stiffness. So one of the things is to look at if someone complaining neck pain, headache plus neck pain, you should consider of this possibility of subarachnoid hemorrhage. Age more than 40 years old, before that patient's been well. Witness loss of consciousness. Yeah. Onset during exertion, thunderclap headache that peak intensity immediately, or limited neck flexion on exam. Again, the neck is being given emphasis, headache plus all this. So this is a level B recommendation in the NICE guideline to do CT. How about lumbar puncture? Is it a must? So for someone coming with a severe thunderclap headache, this is in view of someone you suspect might be having subarachnoid hemorrhage. If they come early, within 6 hours, a CT, a plain CT is enough. We don't do a lumbar puncture. Because the sensitivity to get subarachnoid hemorrhage for someone having this headache within 6 hours that you do CT is 100%. If it is not, there's no bleeding, then there isn't. But despite doing this, if you still have clinical suspicion, then you could evaluate further by doing lumbar puncture. But for some, as an alternative, if you lumbar puncture basically to look for xanthochromia that would present after at least 2 hours of this onset of the headache. That's when you should do the lumbar puncture. And the maximum intensity of this xanthochromia, basically you look at the light that you see is yellowish. If you can't, it's difficult to do lumbar puncture, for example, and you have CT scan. CT scan plus CT contrast is an alternative to CT scan plus lumbar puncture. So CT contrast is an alternative to lumbar puncture. You still have clinical suspicion, and it has a 98% sensitivity to detect subarachnoid hemorrhage. Okay, now how about antifibrinolytic therapy for subarachnoid hemorrhage, like the use of tranexamic acid, for example? There was a Swedish study that showed decrease in rebleeding with the use of tranexamic acid that is given within 3 days. But you have to be careful, patients' underlying risk. If you think that patient may have ischemic risk, if someone having IHD, is not advisable because it could, you might save the brain, but you get a heart attack. So the evidence is not actually making it mandatory. So these are the things that I mentioned just now for further investigation and referral. Someone that's having worse headache with worsening headache with fever, because that can be a meningoencephalitis, a sudden onset of headache. Within 5 minutes, it gets to a maximum intensity. You're thinking of subarachnoid hemorrhage. Someone with neurological deficit, thinking of stroke, cognitive dysfunction, or change in personality, impact consciousness. All these are thinking of stroke. Someone, a recent head trauma. Remember that uncle that fell and GCS full, but having intermittent amnesia. That can be a subacute subdural hematoma, acute on subdural or subacute subdural hematoma, and headache triggered by cough and Valsalva or sneeze. That can be due to some space occupying lesion triggered by exercise. Also, orthostatic headache. Sorry. Yeah. Changes with posture. So some symptoms suggestive of giant cell arthritis. Glaucoma also can cause a headache. And substantial change in the characteristic of the headache. So although we see a typical headache, but allow some space to consider the atypicality or the presentation of the headache for you to investigate further. So these are some of the consideration when you're thinking that, hey, should I, subject this patient for CT scan, for example. So these are some of the further investigation referral to for someone who's having compromised immunity, like retroviral disease or on immunosuppressive drugs. So worry about the possibility of the opportunistic infection. Someone under the age of 20 with a history of malignancy, definitely. History of malignancy, or well, some people may just present with severe vomiting without obvious cause. Keep on having vomiting because space occupying lesion can cause headache plus vomiting. So it may be something sinister in the brain. So as a clinician, we have to think of this character of the pain in front of you to decide whether this patient, we just treat the vomit or you need to do something else more than just giving the antiemetic, for example. So these are some of the practice pearls from American Association of the Family Physician. So according to them, ibuprofen, which is an NSAID, and high-dose acetaminophen or paracetamol, meaning that NSAID plus paracetamol improves acute tension type headaches. So this is something that can be considered apart from just Panadol alone or NSAIDs alone. A combination can improve. Amitriptyline is effective to prevent tension type headaches after 3 months of treatment. Triptans, ibuprofen, all these NSAIDs, and high-dose acetaminophen are effective treatments for acute migraine. So you see the triptan is in front, and then NSAID, and then Panadol. So for me, I think you can consider the Panadol, you can consider the NSAID, you can consider the Panadol plus NSAID. And because of cost, it's triptan. But if cost is not an issue and you are at the center that can prescribe triptan for migraine, go ahead and do triptan. Now, interestingly, magnesium, intravenous magnesium, and greater occipital nerve blocks also, given nerve block, are also effective. So I love magnesium because I use magnesium a lot in my practice for asthma, in fact, for atrial fibrillation, sometimes supraventricular arrhythmias. Magnesium is one in pre-eclampsia, eclampsia. So all this is magnesium is like a big drug, and you don't choose by giving magnesium nowadays. Even the not just asthma, even COPD also we give magnesium. Migraine prophylaxis. All these candesartan, all these sartans, all ACE inhibitors, ARBs, ACE inhibitors, even oral magnesium, topiramate, propranolol, and all these more expensive drug, the erinumab, fremanezumab, and galcanezumab, which are expensive, can be used as prophylaxis. But interestingly, propranolol has been been there for a long time to prevent migraine, but ARBs and ACE inhibitors and oral magnesium, had been also given consideration as a prophylaxis to migraine. So this drug galcanezumab also reduces cluster headache frequency according to this guideline, and triptans and oxygen may improve acute cluster headache. So cluster headaches very much of triptans and oxygen rather than the paracetamol and NSAIDs. Okay, now I want to show you some special situation headache. Remember just now the graph that states that Nepal has one of the highest reported headaches in the world, and what could cause that? So this is my theory. Now, when you go to the mountains, if you climb the Everest or you stay at an area, a high altitude area, you have the risk of developing acute mountain sickness because of the low oxygen pressure, leading to hypoxia, and that's the most common symptoms of acute mountain sickness is headache. So this is a real case because I went to the Everest many years ago as an expedition doctor. So at one of the lodging house at a camp, which was at an altitude of 4,000 meters. So classically, acute mountain sickness would present at an altitude higher than 2,000 meters, or as low as 1,500 meters. There have been reported cases of acute mountain sickness, but typically 2,000 meters and above. So Mount Kinabalu, the highest mountain in Malaysia, is 4,100 meters. But here, when I was there on the way to Everest Base Camp at 4,000 meters, I'm in the middle of the night. I had got a knock on my door that there's this Filipino guy knock on the door and asked me, doctor, can you help my doctor? So their doctor was having the most severe headache. Excuse me. There on the mountain, 4,000 meters. Now, someone having the most severe headache like that at the sea level, you're thinking of hemorrhage. But up there, you're thinking of this acute mountain sickness. And in fact, this doctor, I met him at the level of 3,000 meters. And he told me at that time, he had this headache, and he had been taking acetazolamide, which is a cheap drug for hypertension, a diuretic, and felt better. In fact, this is a drug used to cheat acute mountain sickness, to cheat acclimatization. If you go too fast, high up, you could get acute mountain sickness. But if you take this medication, it can be a prophylaxis and prevent also for treatment if you get that. So the same doctor was the one that sleeping at the same lodging house at 4,000 meters and developed this headache. And at that time, the oxygen saturation was really, really low. But he didn't have other symptoms, like vomiting, not having breathlessness, because at this altitude, we're also worried about high altitude cerebral edema and high altitude pulmonary edema. If you start vomiting, that means it's a really severe acute mountain sickness. So for this patient, this is acute mountain sickness. So I had a problem. Okay, the doctor already took acetazolamide, which is also a treatment for severe AMFs. Now, to give analgesia for this doctor, I have a problem because he was allergic to all NSAIDs. He was also allergic to all opioids, and he was also allergic to paracetamol. So very high maintenance. So but he was not allergic to COX-2 inhibitors, and I was just lucky to have a COX-2 inhibitor in the form of atorvastatin, and I gave that to him. Plus, I gave the steroids, and after giving this, he was all right. So, you know, people are unique. We talk about just now all kinds of the analgesia, paracetamol, NSAIDs, but they may not be able to receive that because of their allergy. So these are some of things to consider. And this is the treatment. Basically, typically for someone having AMS, you treat with paracetamol and for a simple headache. But if the headache is too severe, then you need to, get acetazolamide added and even steroids. But what causes headache in acute mountain sickness? Okay, by the way, that doctor improved and he was able to sleep after that. And the definitive treatment is to go down about 1,000 meters because more oxygen down, and he did after that. So he had no more headache, but he climbed back later on after that. So this is the pathophysiology for acute mountain sickness. When you go up, there is a hypoxia. When there's hypoxia, usually there is a vasodilation of every vessel in the body except your vessels in the lung. This is basic physiology. So on top of that, hypoxia causes the production of neurotransmitters like bradykinin, all these inflammatory mediators that cause leakage to the vessels. So what happens is that in the brain, if the vessels vasodilate, this is how you get the throbbing pain of someone having acute mountain sickness, because there's a vasodilatation, increased intracranial pressure. And if it vasodilates very much, it causes worse pain and you start to vomit. So when you start to vomit, that means a severe acute mountain sickness. So, so that's the thing. If you could get oxygen to them, then this vasodilatation will be resolved and they wouldn't have that headache. So going down is the best, or if they're having oxygen is the best. And painkiller, well, if just something simple, and acetazolamide, for which with the diuretics, you would also, reduce the volume inside. Plus, it also has the side effect of metabolic acidosis that actually makes you breathe deeper and faster, increasing the amount of oxygen inside the body and resolving the hypoxia problem. So in the worst events of acute mountain sickness, it's so bad, the water would leak into the brain, and that would cause the high altitude cerebral edema. Again, worse headache, and cause you not only that, but also to vomit and having an altered mental status. Now, how about this one? I just share with you this case of also a headache in a special situation. A 70-year-old lady with a past history of hypertension, type 2 diabetes, and hyperlipidemia presented to the emergency department with a sudden onset headache and nuchal pain. You start to worry about subarachnoid hemorrhage. Yeah? And apparently he had been having chronic headache for several years, which could be relieved with rest and oral analgesia. And sometimes it's precipitated by anger and stress. So she had no chest pain, but feeling dizzy, dyspneic, and having cold sweat. So usually when patient comes to the emergency department, the ECG would be taken. And if you look closely at this ECG, there is an ST elevation from V2 until V5. In fact, a bit at V6. So there is STEMI, but there's no chest pain. CT scan was done anyway, because we worried about hemorrhage. There was no bleeding. But the cardiac markers were elevated. The echo is inconsistent with the regional wall motion abnormality over the anterolateral area. So it is the site of the left anterior descending artery territory. So this patient was started with dual antiplatelet agents and unfractionated heparin. And patient went for angio for primary PCI, that there was a significant stenosis of the middle segment of the LAD, and stent was inserted. And after that was done, the headache disappeared after the coronary angioplasty. And 4 days after this, patient was discharged symptom-free. No more headaches in the following year ever. So this is what is called cardiac cephalgia. So the heart problem causing the brain, the headache. So this is had been reported as a heart attack that causes a headache, which is called cardiac cephalgia. So now moving towards the last slides of my presentation. So there's this is some of the recent developments. This I mentioned just now about the headache of characteristics of COVID-19, that it could be an esoteric symptom, and the characteristics that it's bilateral, long-lasting headache, and it's resistant usually to analgesia. And males are more frequent, and they usually have anosmia and other GIT symptoms. So this is some of the systematic reviews of the alternative treatments for headache. So apart from all these, the ones that really works had been is acupuncture. I mean, we're talking about evidence-based, but the rest are very much not well established for us to make it as a strong recommendation, except for oxygen therapy in cluster headache. So there's also this thing as new daily persistent headache with an evolving entity. It becomes one of the types of headache that presents more than 3 months, bilateral headache, and it's termed as a new daily persistent headache without a definite classification of migraine or tension headache. Okay, this some of the treatments for new daily persistent headache, and they have tried multiple things like Botox, ketamine, even nerve blocks, so even steroids, muscle relaxants. So these are some of the things that are still in the works in terms of the treatment. Now I mentioned just now about acute mountain sickness, that one must have headache to diagnose plus a minimum score. If you can Google this, it's called Lake Lewis symptom score, and this is actually to diagnose acute mountain sickness. And you see, headache is one of the essential things that you must have headache to diagnose acute mountain sickness. But you may have some gastrointestinal symptoms like vomiting, fatigues, and dizziness. So if you got minimum score of 3, that you're having an acute mountain sickness. So just treatment mentioned earlier, paracetamol, acetazolamide, or going down the mountain. So these are some of the things that in the works of the treatments for headache, but it's still new, like nerve stimulation, magnetic stimulator, ganglion stimulation. So this is just some of the works, but not strong enough. And even nerve blocks especially for chronic headache. This being injected to stop the headache. So I come to my last slide. So this is the conclusion. First of all, the headaches are highly prevalent globally. So we need to differentiate between primary and secondary headache. But we could start by knowing the most common ones, which are the tension and the migraine headache. And we think of secondary headaches when there are other accompanying symptoms that precipitating or worsening that headache. So if you have a headache diary, that helps you to differentiate the types of the headache. And there is a prophylaxis role for primary headaches, and there are multiple drugs for that. And headache has been recognized as a feature for COVID-19. And opioids are generally avoided, especially in primary headaches. And the NICE guideline has incorporated alternatives such as acupuncture. And some of the new options are the nerve block, ganglion block, and nerve stimulations, but they're not strong enough to make it as a suggested treatment. So with that, thank you.
Okay, thank you very much, Dato. Such an insightful lecture you just given. This is our, what we call this, record, We already have 410 participants joining us tonight. Can you imagine? And thank you very much for you guys. The support is really tremendous. Actually, this makes us give us more enthusiasm, to do more CME to you guys. Okay, so now, Dato, we go for the questions. First one is, how to approach headache in the pediatric age group, especially when they came to KK or outpatient department?
Okay, pediatric age group. Okay, this is quite a broad question, and we know pediatric ranges from newborn up to a child, up to adults. So usually it's quite not typical complaint. They usually in our setting, we hardly see a child having headache. So again, this migraine and tension headache usually occurs at the age of 12 and above when they come into a population of adulthood. But before that, it's quite rare. So for a child having a severe headache below the age of 12, there may be secondary pathology, because primary cause of headache usually in 12 years and above. So if the simple headaches that it can be treated with paracetamol, but it disappears. It's probably just something muscular. But if it is something which is chronic and recurrent, that would require further investigation. So some may inherit brain pathology from the infection during birth and whatnot. But in the lower category of neonates, infant, they cannot say they have headache. It's just that they will just be a miserable state. But those who could complain at much later age, if they come with a simple headache, usually it can be just something simple. It may be atypically presenting earlier before an adult, which may be a start of the migraine or tension headache, for which something simple treatment can be given first, like paracetamol. But apart from that, the sinister red flags of the secondary headache, which I outlined earlier, still applies. Someone with, the type of the headache, if it is a worst severe ever headache, even in the child population, you need to actually be worried about that possibility of the aneurysm in the brain, of the subarachnoid hemorrhage, of possibilities that can come genetically. So the answer to that is that first is we have in general, we know that headaches usually not typical in children, but be wary, some may occur earlier. But in making the judgment and assessment, the other guides that was presented earlier for adults still applies. So, and the steps of the managing the headache in pediatric population still applies, starting with something simple like paracetamol, and then going to NSAID as the second stage, and the need for further investigation. The characteristic raises the red flags.
Next question, Dato. What is the reason of giving oxygen for cluster headache? Actually, when I was a physician back then, actually for this cluster headache, actually the one of the pathophysiology, actually they said it's because of vasodilatation, just like what you presented for the AMS. Because of the vasodilatation actually causing the headache, just like a migraine one. So because of the oxygen, actually this is what the one that I can remember when I was practicing previously. Actually, the oxygen does cause vasoconstriction, high dose oxygen, and patient does improve actually after 15 to 20 minutes. They really improve. How about your opinion, Dato?
Yeah, it's the same. So the oxygen effect at the high flow would do just that, making the vessels there smaller. And in that sense, with the oxygen giving the effect of the inflammation that is happening, improve the sequelae of the headache. Yeah.
Next question. This is a lot of question about this only, Dato. I think more 6 or 7 questions regarding this topic only. For migraine, recommendations suggest triptan. How about Cafox that contain ergometrin? Sorry,
what was the question again?
For migraine, recommendations suggest triptan. How about Cafox that contain ergometrin?
Cafox. I'm not familiar with that.
Yeah, actually, this one actually mostly the GP actually have it a lot. They give most patient with migraine Cafox. Actually, this one I noticed previously lah. Yeah, we know that we don't prescribe it in the KKM. We don't actually prescribe Cafox. Just whether you have any experience actually treating patient with Cafox.
I'm sorry, I don't have experience treating patient with KFOX. It's not available at my center, so I'm afraid I can't comment on that.
Yeah, sorry, because also actually it's not in the recommendation also. That's why actually it's not in the KKM list for the medication in the hospital. Okay. Next question is for patients that are recently diagnosed as ACS, started on daily aspirin treatment. If said patient suffers from medication overuse headache, what would be the best course of action?
That's interesting. I've not come across such a case. Yes, aspirin is one of the NSAIDs. But usually when we talk about that medication overuse headache, it's because of the usage of the analgesia of that to address the headache. But as a result of that, you get headache. But if you notice the dosage for aspirin that is being used for acute coronary syndrome is much lower. To my experience, at least, I've not got anyone who had taking aspirin presenting with headache to date. I'm not sure if there are anyone who had that experience, but I believe that you don't see this because of the dosage recommended is pretty low, 150. In some cases for treatment, the aspirin dose may be higher than that, 300 ke atas that you treat, and yeah, that's the reason.
Okay. Next question is floor cluster headache. Is there any definite duration of all oxygen treatment?
No. You would start that off initially. There is no you have to give for how long, but you have to give that as the first line, and usually you would see it still doesn't improve. Go for the second line, one which is recommended. Most of the time it works, but you just need to know that there is a second line in the form of triptan. For this, you have to liaise with your pharmacist or your neurologist.
Okay, Datuk, next question is mostly it's for the ED team, Datuk. Datuk, clinically, how do we differentiate between hemiplegic migraine and stroke in those presenting with headache and muscle weakness?
It's hard. In fact, the recommendation, if you see someone, unless it's recurrent and the patient can tell you, this is normal for me, once my headache goes off, then I will regain my motor. But if it is a first-time presentation, you will have to treat it as a stroke. Just like I mentioned just now, the red flag. Yeah. So go for CT, activate your stroke protocol for such patient.
Yeah. That's the best way, yeah. So you can get the diagnosis very fast. So next question is, how does patient usually say when the pain or headache precipitated by Valsalva?
Well, probably naturally is that when they are doing the when they naturally do the Valsalva, probably in the toilet. So basically, is they are blowing against closed orifice or closed mouth. So that would worsen the headache. So yeah, I would say that. So yeah, this is also not like very clear cut. But if it is noticed that someone who every time he goes to the toilet and that headache comes, so maybe something that may be of concern, especially if it is significant.
Okay, since we're talking about this Valsalva, just want to share, since I'm in IJN, for those who are doctors who are seeing a patient with this vasovagal attack syncope, please refer to cardiology, because now we have a better treatment. We can do ablation, cardio-neural ablation for this kind of patient, and then usually the effect is quite good. First, we give medication treatment first. If not working, then we can do a ablation for this kind of patient. Okay, next one. Patient with underlying carcinoma frequently have headache. How to reduce the headache? Actually, this one you need to actually refer the patient to the neurosurgical. Actually, you need to take out the carcinoma. Actually, the answer is basically that. Actually, still once the tumor is still there, you cannot relieve the headache. I go to another question. Okay. Hi, doctor. I want to ask regarding cardiac cephalgia. If I suspect patient having cardiac cephalgia, it is compulsory to do CT brain prior to start the SCS treatment.
Yeah. Yes, I believe so. You have to rule out the bleeding in the brain because especially someone who has a characteristically or severe headache, a significant headache at least. So we have that's kind of our practice even in ED. When someone coming to ED before we start thrombolytics for someone having STEMI, if someone present with a severe significant headache, we would CT first, or someone having altered mental status, we would CT first before going to the heart. So once we're cleared of the bleeding, then only we start the even the aspirin, even the clopidogrel, or all the antiplatelets. And yeah.
Okay, Datuk, there's a lot of questions, but this will be the last, Datuk. Since that you said that you like magnesium so much, what is the dosage of IV magnesium they use for headache?
The usual 1 ampule of the magnesium is quite harmless, given in a proper manner, meaning that usually we typically give it within 20 minutes. So I would go with that and for a trial.
Okay. Okay, so as we end our question Q&A session, we extend our heartfelt appreciation to Dato' Alza for delivering an exceptionally informative lecture on the subject of headaches. The overwhelming participation for today's attendees brings us a great joy as it fosters and increase our engagement and interaction. These interactions serve as a catalyst for our dedicated MedTweetMY team, further igniting our enthusiasm and drive our organized future continuing medical education CME events. We extend our deepest gratitude to everyone involved. We would like to inform you that the recording for today's lecture will be made available on the MedTweetMy YouTube channel for future reference. Additionally, we kindly request all participants to register for the MMA CPD point and e-certification via the provided link, and the link will be closed at 10 p.m. The points will be awarded in early August, ensuring proper recognition of your participation and commitment to our ongoing professional development. Once again, we express our sincerest appreciation, and we look forward to serving you with more enriching educational opportunities in the future. Thank you very much, Datuk.